Welcome, everyone. On behalf of the Centers for Medicare and Medicaid Services, the Administration for Community Living, and the Indian Health Service, I would like to welcome everyone to the Long-Term Services and Supports webinar series. My name is Anna Whiting-Sorrell, and I work for Kaufman and Associates Incorporated, KAI. I will be your moderator today. I'm really excited as we bring the third in a series of webinars entitled Seasons of Care, Maintaining Health, Part 3. This webinar series is supported by a contract by the Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in the webinar are those of the presenter and do not necessarily represent the official position or policies of the Department of Health and Human Services or the Centers for Medicare and Medicaid Services. Today, I'd like to reintroduce, for those of you that have been on previous webinars, our presenters. Emily is not going to be able to join us, but we have Elise Hamel and Kathleen Wilging. Elise is a research scientist at the Pacific Institute for Research and Evaluation, and her colleague Kathleen serves as the center director and the senior research scientist. So I'm going to go ahead and turn it over to Elise.
Hi, thank you. Thank you all for joining us. So on the next slide, I think we have the objectives for our webinar today. Our three objectives are first to understand the importance of having a consistent healthcare provider, especially for older folks. Second, to identify the conditions that lead American Indian elders to not have a healthcare provider based on the research that we're going to talk about. And then third, to describe the factors influencing American Indian elders' satisfaction with health services. And then we'll conclude with, again, talking about some recommendations about how to improve healthcare for our elders in general, and specifically how to work to connect American Indian elders with healthcare providers. And so for the first section of the presentation, I'm going to give the presentation over to my colleague, Katie.
Good afternoon or good morning. I also want to acknowledge our funder, the National Institute for Minority Health and Health Disparities. They made this work possible. So I'm going to give you a quick overview of our study. It's called the Seasons of Care Study, and it is a community engaged project focused on healthcare issues for American Indian elders in 2 Southwest states. Just for some basic context, members of federally recognized American Indian tribes have a legal right to health care, as I'm sure most of you, if not all, are aware. And the Indian Health Service is the safety net, is one of the primary providers of healthcare to American Indian tribes throughout the nation, and it includes hospitals, clinics, and programs that deliver primary care to over 2.5 million American Indian and Alaska Natives. For services that can't be provided through the IHS, referrals could be made through Purchase Referred Care Program. Because of chronic underfunding by Congress, there are issues sometimes with quality and availability of care. We have a very large population of American Indians living in metropolitan areas and outside reservation settings, but only 1% of the Indian Health Service budget actually goes to funding urban clinics. And there's no line item for elder care to pay for services such as assisted living. We do know that health insurance enrollment can help American Indian elders get and pay for care. And this includes enrollment in programs such as Medicare and Medicaid. So let me give you some background on our Seasons of Care study. And this was a study that was really brought into fruition at the due to collaboration with a retired surgeon from Taos Pueblo, Dr. Ron Lujan, who brought together a group of Native American elders in the Southwest who were concerned about healthcare and healthcare access issues for elders. And they really helped design the study that we're going to be talking about today. And our study was designed to answer 3 main questions. The first is, how do elders understand, access, maintain, and use health insurance? What are their experiences with help seeking and getting care and receiving care? What factors affect their access to health care? And we use this information to develop and then test an online navigation intervention for elders, for their caregivers, and importantly for providers who work with elders and their families to improve access to healthcare and health insurance. The participants included elders, tribal leaders, and health professionals who work with elders. We did surveys and we did interviews. So this is a mixed method study. It's quantitative. So the surveys give us numbers, and it's qualitative. So the interviews, that's where we're interested in people's stories and hearing about their experiences in their own words. So we did surveys with elders. We did semi-structured interviews with elders and the other folks who participated in the study. We did something called concept mapping that Elise is going to be talking about a little later in this presentation. We also created a web-based navigation guide, and we can drop that into the chat box. And this whole project, again, was designed and it was overseen by a community action board. And this was a group of elders who helped facilitate all aspects of this project, from helping us get approval from tribal entities, to helping us recruit, to also helping us hire elder consultants. And these were elders in many of the communities in which we worked, and they helped us actually collect the data. And our community action board also worked with us to review and interpret our findings, and to really highlight what we should be sharing with others, and what are some of the best ways to share that information. So this community action board was absolutely pivotal to this project and its success. So I'm going to be touching upon the causes and consequences of not having a personal health care provider among American Indian elders. So I'm going to be touching on our study data that really delves into this issue. And here I'm going to be drawing from both survey data and from our qualitative or our interview data. So one thing we do know from the broader literature is that having a consistent and reliable relationship with a healthcare provider is strongly associated with, being satisfied with your healthcare, having lower healthcare costs, experiencing better health outcomes, less illness and mortality, and reduced risk of preventable hospitalization. And not having a relationship with a healthcare provider is strongly associated with longer hospital stays, more hospitalizations, greater unmet healthcare needs, experiencing problems with medications, and poorer health outcomes. So about 25% of US adults report not having a personal healthcare provider here in the United States. And the common reasons for not having a personal healthcare provider include, being part of a minoritized population based on race or ethnicity, not having health insurance, and the cost of medical care, and also including the concerns about the cost of medical care that sometimes lead people to delay getting the kind of care that they might need. So we asked our elder participants, a personal healthcare provider is a provider who knows you well and is familiar with your health history. Do you have someone who you think of as your personal healthcare provider? So we asked all the elders who participated in our study this very question. So for this analysis, we took our data and we looked at elders who indicated they had a personal healthcare providers, And we compared their experiences with those elders who said they didn't have a personal health care provider. And we looked at differences in terms of their demographics, like, for example, their age, their health status, their healthcare use, and their satisfaction with healthcare. And we analyzed interviews of elders without a personal healthcare provider. So we're going to do a deep dive into that today. And we also compared survey and interview findings. So elders who did not have a healthcare provider were more likely to earn less than $12,000 a year, to not have the internet. And we know a lot of things are dependent on the internet these days. And they were also more likely to rate their health as fair or poor. So 33% of our sample did not have a healthcare provider, and close to 67 did have a healthcare provider, which is, it's great how many people did have a healthcare provider, but we're not talking about this so much today. I think we talked about it in prior webinars. There was still, a lot of turnover amongst providers. So they didn't, have these providers necessarily long-term. So elders without a provider were more likely to have trouble finding a doctor who would see them. They were especially likely to delay care due to, long wait times at healthcare facilities. So it's just the anticipation that they would have to wait that led them to delay care. They were also likely to opt out of filling prescriptions due to cost, and to also receive unexpected medical bills. Here's a little bit more context. We did ask people in the previous 12 months, doctors listened carefully and explained things in a way that I could understand. So this is something that people with a healthcare provider endorsed versus those without a healthcare provider. In the previous 12 months, I was very satisfied with the care I received. So you see here again that people were likely to be more satisfied if they did have a healthcare provider, and definitely less likely to be satisfied if they didn't have a healthcare provider. And then I'm extremely or very confident I can get the care if I need it. Again, you see a discrepancy here. If people had a healthcare provider, they did have a greater confidence that they would be able to get their health care. Some of the reasons that people expressed for not having a healthcare provider is that they were in good health. And you especially heard this from elders who were younger. And there was also an ethic of self-reliance. So here we have a quote from a man in his later 50s. I guess when I'm actually really sick and if I can't cure myself from taking over-the-counter medications, then I guess I will have to go see a real doctor. But it hasn't happened, knock on wood. And then another person said, I don't have anybody. And they talked about how they, they felt able that they could take care of themselves. They could be self-reliant. They did talk in their interviews about overlapping barriers to care, including, as I mentioned, in the survey findings, the long wait times. They talked about not knowing how to find a provider. And they also talked about their frustrations with provider turnover. And this was often provider turnover in the Indian Health Service context. So one, a fellow in his mid-60s, close to mid-60s, said, they'll assign you a doctor, but you don't know who it's going to be. Then it won't be for another 2 months before you can get in. Then you have to go and they have to do a blood test. Then the next time we were going to make an appointment and he's leaving. Then when you go in, you wait almost 20 minutes before you even get screened. Then you see the doctor and you're out in 10 minutes. Then they'll do a referral to you. Then maybe another month later, they'll say, okay, it's approved. All those things come about. So not being able to, see the same doctor consistently, and then experiencing these challenges when you're in a healthcare encounter can, lead people to, just take a break in their help-seeking process. So they're just not going to follow through, or the anticipation of all this stuff happening can, keep people from actually going to the doctor. And then there's also fear and mistrust of medical care that's, very much rooted in trauma, both historical and at the individual level. So here is a quote from a woman in her early 60s. "I really hesitate to go see doctors because they tell you, you're this, you're that. Like every time I go there, the IHS hospital, they tell me I have high blood pressure. My mother, she took all these medications, and I think that just probably affected her whole system. And I think that's why I just hate to go see a doctor." So there is this anticipation. There's often like what people experience in their own like family context or among their close personal friends and what experiences they had. And there is this fear that, you're going to get labeled as having this illness. And then there's this fear that there's going to be a negative trajectory. And then there is, again, the mistrust of the medical system. Along these lines, here is a quote from another man in his late 50s. The doctor wanted me to take it, but I said no, because I know that nationwide, a lot of natives have become diabetic all at once. I just said, I can't get on insulin. I don't want to get on insulin. So here is just, the fear of the medication, and the medication actually kicking off a negative trajectory. And this, again, this fear makes people a little bit, hesitant to use what health services might be available to them. And it's also linked to not having a personal healthcare provider that you can trust. So here we have a question for everybody, and you can drop your answers in the chat. Which of these themes resonate most with your own experiences working with elders or as an elder, and which are surprising or confusing to you? Anybody want to let us know, like, are these things that you're kind of already aware of? You might see this in your own communities, or even in your own healthcare settings, or is anything new here or surprising? Lack of trust with government. We definitely heard that in many of our interviews. And what was interesting, though, is like people did express a high trust oftentimes in the IHS, especially if they had been using the IHS for many, many, many years. They were sometimes a little bit more skeptical about going outside of their particular community for care. So some of these things don't like always neatly line up. Does anybody else want to drop in the chat, what themes resonate most with you, or what might be surprising? All righty. Well, if you do have ideas, drop them in the chat. But thank you, Tatiana, for your chat message. And I think I am passing on to Elise right now. Oh, not enough direction when given a referral. That was another theme that definitely came up. I don't know if you want to elaborate on that, Elise.
Yeah, I think, we don't have a infinite amount of time today, but I think the complexity of the number of systems that elders specifically had to deal with, and that's another difference that I think American Indian elders might experience, that they're dealing with IHS, but they're also dealing with other kinds of systems that they have to be referred out to, and there might be disconnects between one set of providers and another set of providers and the insurance. And so, that was certainly a big barrier. And I think could be so complicated that elders that we talked to said that they just didn't even want to try because it was too frustrating for them. And then I see this other message about tribal councils, and actually in this next section, we'll talk a little bit about that too. So these are definitely experiences that resonate with the elders that we worked with as well. So yeah, so in conclusion, we really found that elders who had a healthcare provider had a much greater likelihood of having better access to care and better experiences with healthcare than elders that didn't have a healthcare provider. And so in the next section, we're going to kind of dive in a little deeper into some of those factors that are affecting elders' access to care and their satisfaction with care, and kind of delve into some of the differences between groups of elders. So for this piece, we're going to talk about another section of our study where we used a method called concept mapping. And so I won't go in too much detail about the method, but it's a really interesting method. It's a participatory method where you can work with your participants to look at the different factors that were affecting elders' access to healthcare and their use of healthcare, and then to kind of organize and prioritize those factors. So organize them into themes and kind of prioritize them in different ways. So to do this, when we did our interviews with elders and other folks, we asked, one of the questions we asked was, what makes it easy or hard for American Indian elders to get good health care? And so then we compiled all the answers to that question, and we kind of sorted out the redundancies, and we ended up with a list of 61 factors that were responses to that question. So things like difficulty getting transportation, provider turnover, different kinds of factors, some of which you'll see here later on. Then we took those that list of factors back to another group of elders, and we asked them to sort the factors into themes and then to label those themes. Then we also asked them to rank the factors from 1 to 10 based on how common they were. So they saw a whole list of factors, and each factor we asked them, how common is it? Is it very common or not very common among elders? We also asked them to rank all the factors based on impact. So how much does this factor affect elders' health? Does it have a big effect on elders' health or not very much of an effect? And finally, we had asked them to rank the factors on changeability. How easy would it be to change this factor? And you'll see some of this data here in just a minute. And then we kind of compared the themes and the way that participants ranked the themes between the types of participants. So we compared elders' perspectives on these things with the perspectives of, for example, tribal leaders and health administrators. And then we also compared different groups of elders. So we compared women and men, and we compared older elders, meaning elders that were over age 65, and younger elders, which meant elders who were 55 to 64. And so here, again, we're just looking at kind of themes in the kinds of barriers that elders experienced and how common they were among elders. So there at the bottom, those are the groups of themes that were identified through the concept mapping. So we had, again, a list of 60 factors, and then overall, they were kind of sorted into these themes. And they included tribal and national policy, insecurity from lack of knowledge, so issues with having being unsure about how to find information and what to know about healthcare. Then provider issues and relationships, so some of the things we've talked about today, accessibility and transportation barriers, scheduling, scheduling challenges, family and emotional challenges, limited availability of services, health-related self-efficacy, so that one meaning not being able to kind of advocate for yourself or not feeling confident enough to ask questions or something like that. And then finally, difficulties obtaining and using services. So these were sort of the broad themes that describe the kind of barriers that elders were experiencing. And here you can see the rankings in terms of how common these themes are. And I'm not going to talk about each one in detail, but you can see that both elders and the other stakeholders, meaning the tribal leaders and healthcare providers we spoke to, were kind of in broad agreement that tribal and national policy issues were very, very common. Those are issues like lack of funding by Congress, tribal governments not maybe prioritizing elder health care, difficulty accessing services coming from the federal government and the state government. Those kinds of things were very, very common, and issues with kind of lack of knowledge and providers kind of followed up in terms of commonality. So we can see that those were considered the most common among elders. And then here, this is the rankings of how impactful these factors are on elders. So how much of an effect do they have on elders? And again, these factors are kind of falling out in the same way. So that tribal and national policy piece being the most impactful, lack of knowledge coming up second, and then the other factors kind of following there: provider issues, accessibility, scheduling, things like that. And of course, all of these were rated as pretty high impact, but those first couple were really, really important. And then the next slide, please. And then finally, how easy are these factors to change? And you can see that here there was not much difference. So everybody kind of ranked all the factors as being pretty tough to change. So kind of right there in the middle, not impossible to change, not easy to change, but sort of right there in the middle. And I think there you can really see how some of these issues are persistent over time and can be kind of intractable and difficult to affect. And so these are some of the things that we're trying to figure out in our research and work, is how do we change some of these things? So here, this is, I think, kind of interesting, where you can see differences among elders. So here we're looking at the perspectives of women and men and the perspectives of older and younger elders. And so I'll point out some things, so it's a little hard to interpret this table sometimes. So this is the way that different groups ranked the factors in terms of how important they were. And I highlighted the kind of first most important, the second most important, and the third most important for each of these groups. And so what's interesting here is that you can see that tribal national policy, provider issues and relationships, and scheduling challenges were in the top three for most of the groups. So those are those ones right at the top. But then you can see a few outliers here. So you can see that older women age 65 plus, they put accessibility and transportation barriers as the most important factor for them. And that's different from a lot of the other groups. And we'll talk about why that might be in just a minute. You can see for slightly younger men aged 55 to 64, they ranked self-efficacy, that's that ability to advocate for yourself, and health insurance problems as being very impactful, much more impactful than the other groups did. And then there for men age 65 plus, you can see limited availability of services. They're ranked in the top three, and then didn't for the other group. So we'll talk a little bit more about what those things mean here. So here's some of the kind of conclusions from that data, which I know is a little hard to interpret. So we found broad agreement across men and women and among all age groups of elders that issues with providers, so, communicating with your provider, getting an appointment with your provider, understanding what your provider tells you, those kinds of issues, and tribal and national policy issues have a significant impact on elder health. So that was broadly agreed upon. Those kinds of factors also included difficulties associated with interactions with healthcare organizations, so things like long waits that we talked about earlier. It also included difficulties with unfamiliar technology. These were elders that maybe had a hard time with computers or the internet, and a broad perception that the policy environment was indifferent to American Indian elders, that their healthcare was a low priority for national politicians and for tribal leaders. And then, so here's some of the conclusions we can reach about different groups of elders. So as I noted, factors that were ranked as most impactful only among men included not having a regular doctor. So that's what we were talking about earlier, not having a regular healthcare provider. So that really showed up most strongly among men rather than women. And then factors ranked as most impactful only among women, the one that showed up there was difficulties dealing with the emotions related to healthcare. So feeling like you might be a burden, feeling like your family was going to have a hard time dealing with things that were happening to you, being able to communicate with people that you loved. And so we know that for female elders, that they are maybe more than elders dealing with some of the emotional and financial weight of caregiving and the fear of becoming a burden on others. And so some of this data kind of highlights that fact. And then we also note that women have a higher life expectancy, and so they are more likely to encounter some age-related accessibility barriers. So not being able to drive, maybe having some language differences that are more common among older elders. And then also maybe the danger of losing social support as they lose their friends and family because they have a higher life expectancy. So some of these burdens are maybe more likely among women than among men. And then for men, we really found a higher rate, a more commonality of lower rates of healthcare use and not having a relationship with a regular provider. So that was a more common issue among men. So then here, looking at the age differences, we found that only among younger elders, difficulty scheduling appointments was ranked quite high. And then among older elders, some of the factors that were ranked very high were not knowing how to influence tribal leadership, the perception that healthcare was a low priority for tribal leadership, and having a hard time getting referrals to other care through the purchase referred care system. That's the sort of system that provides referrals to specialty care for IHS users. So some of the conclusions that we can draw here about age is that younger elders, these are again elders age 55 to 64, might be more likely to encounter difficulties associated with a lack of familiarity with the healthcare system. So they might not have had as much cause to use the healthcare system, and so they might have a harder time scheduling appointments, advocating for themselves, things like that. So they might be less familiar with the need to do those kinds of things. And then younger elders are also going to be affected by health insurance enrollment issues. So elders that are age 65 and older are going to be much more likely to have Medicare. Elders that are younger than age 65 are much more likely to have issues with health insurance and not be enrolled in health insurance. And that's going to mean that difficulties with getting providers and scheduling appointments are going to be more common for them. And then for older elders, we really found that they were more likely to have issues with navigating the complex bureaucracies. So as they have more complex health issues, as they need more care, they're going to be having to navigate the referral systems and different health insurance systems more than younger elders are going to have to do those kind of things. And then also that they specifically felt that they had a hard time accessing tribal decision makers and affecting tribal leaders. So those were things that came out more commonly among older elders. So I know this is a lot of information, and so here we're really just trying to understand some of the differences between women and men and between younger and older elders. And so here I'm going to pause again and take a look at the chat. And ask if anybody would like to share anything here that resonates with you and your experience, or anything that you find surprising or confusing that we can talk about a little bit more. So I'll pause for a few minutes here.
What I find is interesting while we're taking this pause is that you often don't see these differences in terms of what people are saying in terms of, age and in terms of gender, and really getting at, some key concerns that different segments of the elder population have. And I think that also tells us we need to be, tailoring our intervention approaches to these different concerns that are articulated.
Okay, this is a great question. So Josh Rohrer here asked, did the elders agree with or have reactions to the conclusions drawn for their demographics? So this is a great question. So as part of our participatory methodology for this study, we did bring the conclusions back to different groups of elders and specifically to our advisory board of elders to help them, to ask them to help us interpret and prioritize our findings. Excuse me. And so a lot of those conclusions that I mentioned, so for example, we saw that finding where older women rated accessibility and transportation. And then coming from that theme, we kind of talked about how older women have a higher life expectancy. They might have more age-related barriers. They might have more caregiving burdens, those kinds of things. That interpretation and kind of fleshing out of some of those barriers really came from our consultations with our advisory board and with other groups of elders. So they several times in different groups looked at sort of the raw data and the different rankings, and through conversations with these groups of elders over time, we drew out some of the conclusions and understandings of what some of these patterns meant. So thank you for that question. Okay, great. Well, we'll have some more question and answer time at the end, but we're going to conclude with some recommendations. And so I'm going to pass it back to Katie here for the last couple of slides about recommendations.
So many of our recommendations, they really concern funding, elder-specific care, workforce issues, and culturally congruent care. I will say, we in all the articles that I just dropped in the chat, this is always the key finding. And in a lot of the articles that you'll come across on elder healthcare, and American Indian healthcare in general, there is always a recommendation to fund the Indian Health Service at 100% of need, because we know that it is woefully underfunded. And that's why a lot of the issues that we described today are happening. With funding, there is a need to allocate, financial resources specifically for elder-specific healthcare needs. This needs to be a priority. We also know from our study that elders really do appreciate when they have help from community-based navigators, people who know the system and also know their community. They want people who can help them access care across different kinds of healthcare systems, because they're not only receiving services from the Indian Health Service. There's also a need to implement social support programming for elders who might be experiencing or at risk for social isolation. And also, I think this was touched upon earlier when Elise was talking about older women whose social support networks might, be diminishing as they age. And it's really important to provide them with the resources and the emotional nurturing that they need to maintain their own wellness. And clearly the elders in our study think it's essential that elders need to be consulted with when considering changes and improvements to the healthcare system. Yes, caregiver support is also a huge issue, and that's something that we talk about elsewhere, but that should be in terms of funding services for elder-specific healthcare needs. I think that falls under that. It's really important to address workforce turnover at IHS healthcare facilities. This is a long-standing problem. And it impacts some communities more than others. It definitely impacted the elders that we spoke with, who talked about being able to develop rapport with a healthcare provider, and then when returning for their next visit, finding that healthcare provider is no longer there. And this kind of experience is what makes people less likely to keep going back for healthcare services, but it also makes people less satisfied and less trusting in the care they're getting and satisfied. It's also important to improve continuity of care. And maybe we could talk about ways to actually do this, but workforce issues are central and need to be something that we also need to dedicate financial resources to addressing. Again, many of you are probably aware of this recommendation as well. It's essential to train new providers on cultural, historical, and individual level needs when providing care to elder patients. There's a lot of stereotypes about elder patients, and I think what our concept mapping does is really break down there's some key differences. These are differences we need to be aware of, and we also have to understand that elders do not comprise a homogeneous population. And we need to be looking at the different cultural contexts in which they live, in which their well-being takes root, and providers need to be aware of these issues. And also, how to communicate appropriately with elders. We need to address mistrust and low confidence that some elders have of the healthcare system. And this can be done through, focused outreach, as well as through the provision of navigation support, as mentioned earlier. And we need to be able to address patient satisfaction concerns appropriately. We should be asking patients how satisfied we are with their services, and we should be doing something with that data. That's something that we need to be working with our healthcare institutions to do, and also with our providers. So this is just, I know, the tip of the iceberg in terms of suggestions. And I think the big one is always funding. But we'd love to hear your suggestions for how we could also make care better for elders, and that includes improving access to healthcare providers on a consistent basis. Anybody have any thoughts or comments or maybe questions that don't even relate to this query? And Elise should feel free. Another caregiver support, local NGOs. I'm going to ask, what does SHIPS stand for? I don't know if everybody's going to be familiar with SHIPS.
These are state health insurance programs, right?
Yes. But that is also something when we're talking about state health insurance programs, what we've learned in our study states is oftentimes the people who staff those programs really aren't aware of the complexities of how healthcare is organized and financed for Native people, and what might be covered by IHS and what's not. Even within those programs, there's often this assumption that IHS is going to take care of all the healthcare needs of elders when that's not the case. So we need to be focusing on those folks as well to ensure that they know about elders' needs and the complexities in terms of the different bureaucracies.
I will also note that, in the findings about elders that didn't have a healthcare provider, I mean, the finding about mistrust and fear around the health system, there was a large part of that had to do with both the perception that the healthcare system was hostile to American Indian folks, historically and now, and also the perception that the US healthcare system was in general insecure and not trustworthy. And so I think relying on health insurance for some elders was hard because I think they felt that either they shouldn't have to rely on health insurance or that they just didn't feel like it was trustworthy, that they weren't sure that they were going to have health insurance. They weren't sure that it was going to pay for everything. And so while providing access to these kinds of programs is important, I think we also, one of the big findings of our research is the importance of understanding and working to overcome those feelings of fear and insecurity. So even though there may be things available, really understanding why elders may choose not to access them and kind of what the roots of those decisions are in their experiences and their community's experiences, and that's a kind of a deeper problem that has to be addressed, both kind of on a local level and on a national level.
And then I want to just respond to Josh's comment, and then we can unmute Tatiana, so because she has some comments to share. But Josh, I mean, how can states work with tribal entities in a way that respects their nation status? I mean, tribal consultation was something that was brought up multiple times in our interviews, multiple times. And it was something that people saw as requiring serious strengthening. And oftentimes this is because the people who are doing the consultation who aren't from the tribal communities really don't have the background. And oftentimes, at least in our study states, there was this perception that the state's going to do what it wants. And they didn't really see that the consultation was a true consultation. So I think we really have to just we need to use that mechanism, and we need to be able to make sure all parties involved, are able to engage in this respectful dialogue and to really make meaningful change so that, people from tribal communities don't feel like they're just going there to rubber stamp a decision that's already been made. But I think that's like a key mechanism that we need to really be thinking about. And Elise, I don't know if you have anything to add on that.
No, that sounds great.
And then I know Tatiana had a comment.
Yes.
Hi, thank you for the opportunity, because addressing several things several years ago in California, we California health advocates were fortunate enough to be able to get a grant from a quite well-to-do nation to do clinic education and elder education on the importance of Medicare, and to save money for the Indian health clinic so that they could divert some of those IHS dollars to other initiatives. And we've been successful to the point where we're able to add a tribal tab to our website. But we also provide supports to the SHIP, the State Health Insurance Assistance Program in California, they call HICAPS. One point of reference is that the Older Americans Act, which provides the funding for the area agencies on aging, have a requirement to outreach and provide services, culturally appropriate services, to the Native American nations, albeit it's slow, it's very small, but I took it upon myself to educate myself more on the different nuances of how to elicit the respect and the trust of tribal nations and their elders. I just went to one of the nations in Santa Rosa yesterday to do some Medicare counseling for those who are new to Medicare. That's very important because as we are all aging, the elders are unfamiliar with what they have to do. And the clinics are also shorthanded. So we work hand in hand with the clinics. These are just tips. If anybody would like to contact me, I will put my email address in the chat. Thank you.
Thank you. I'm gonna say one thing, and then I think Elise will have several thoughts to share, but the comment you made about you took it upon, I took it upon myself. What we have found in our study state is that it's the people who volunteer and take it upon themselves to really go out there and educate elders. Like, they have a phenomenal impact. What we've found is there haven't been the dedication of resources to do some of that work. And what we do find is sometimes people will go into some of these tribal communities and there is a high level of suspicion, especially when there might be a product to sell, and there is mistrust. So that's why that navigation component, I think, is so absolutely critical. But it really, at least in our study context, it really was like dedicated people on the ground who wanted to do this work, and they kind of self-selected for it. Elise?
Yeah, I think that's definitely true. And you know, we worked in a lot of different communities, and it really varied from community to community. So sometimes we'd have communities where there was one person that was really knowledgeable, that over and over again would come up with in our conversations with the elders, and they would all know this one person. This is the person I go to. This is who I ask, whether it was a benefits coordinator, whether it was a community health representative. And that's awesome. And those resources are incredibly important. A lot of the times that was somebody who was from the community, who had their own elders that they were caring for, that had developed a passion for their community and for their elders. And so I think those resources are incredibly important. I think that it can also be an undue burden on folks like that, because of the gaps in insurance and the social safety net more broadly. I think communities, do really lean on people like that. And I think, when somebody like that has to go, when there's turnover, if they have to go for some other reason, we also came across, I'm remembering specifically one community where somebody that they had really depended on had to leave their position. And so again and again in interviews, it came up, well, I used to go to this person, but he's not there, so I don't know where to go anymore. And people were really at a loss because they had lost that person. And so I think attention to those community level and culturally congruent resources are really, really important. And I think probably get overlooked. So I really appreciate you bring that up, Tatiana.
And just to add, the state could be doing a better job. Liaisons for managed care companies could be doing a better job. I don't think we're investing in the way that we need to. And Elise and I are always available for questions after this presentation. You should feel free to, drop us an email. We can put our emails in the chat. But we definitely thank you for taking the time this afternoon to come to today's presentation.
Yeah, I see Tatiana also mentioned elder abuse and scams, or elders and families to be subject to scams and abuse. That's definitely true. It was also just briefly interesting because in our research, a lot of the communities that we worked in had done a lot of work educating elders about scams. And so then there was a sort of what's the word? I can't think of a backlash. So that then it was sometimes hard to contact elders about anything because they were so worried that it was a scam. So it's a tough balance there.
And
And I would like to give a shout out to Emily Houses, who is our team member, and she just couldn't be here today, but she helped, create today's presentation. She also is the co-author of many of the articles that are included in the chat box.
well, I would like to thank Elise and Kathleen for joining us today. Please take note that their email and their phone numbers are on the screen, so you can take them. Thank you again for joining today's webinar, and our session is now concluded.